Thank you so much for coming here, and thank you to my panelists here. So today we're going to talk about how medical imaging can enhance life sciences research. So the format that we have chosen to do is we'll give very brief presentations in the beginning, so that we have certain points to discuss about, and after the presentations we'll pose some questions. We'll discuss among ourselves, and then it will be open to the audience as well. So initially, I would request you to start the presentation.
Thank you very much. So usually it's very difficult to have a speech after the lunch, but the good news is that there are few of you, so it will not be very hard. I hope so. Can you please get this presentation started? Okay. So actually, we had this agreed together to have this arrangement. So I will give a basic presentation about how medical imaging and impacts the life science research. So, of course, as an introduction, we all familiar with medical imaging, which has an important role in research and in life science in general, and it has a big role from the lab to the clinic. And while most of us here, or those who are outside also, they know that having the medical imaging role in clinical practice in the doctor office is very important. But again, still, this is only one aspect how medical imaging affects or impacts the clinical research. So, to give you an overview, what is imaging in clinical research can do, I think there are four main functions for the medical imaging. That's number one, you can chart the patient progress. So having some lung CT or X-ray to follow the disease to understand how it works. Also, it could be a way to monitor the patient's safety. So for some patients, you can do an echocardiogram, for example, to see if the heart is affected or having some toxicity. So that's a safety aspect, important. And another one is to confirm whether the new therapy is working or not. So the effectiveness of the study or the research you are doing. And this, for example, cancer patients can have a PET scan to see if the tumor has shrunken or not. And this is one value for medical imaging in clinical research. Last but not least, an interesting aspect is that sometimes you can have imaging in real time to learn how the patient is reacting to this. So sometimes patients are having IV treatment. At the same time, an MRI is done so that you can examine how the brain of the patient reacts to the new drugs or the new medication you are giving at the same time, so in real time. But what I wanted to speak about specifically is a different dimension, which is imaging at the cellular level. And very interesting and rather new thing called the X-ray histotomography, and I will explain in quite a bit what does it mean. And you can see this interesting image showing what is X-ray histotomography means. So to start, that's a histology. That's one of the key advances in medicine, which helped in the previous centuries how to diagnose disease, because histology means it's a technique to understand what is normal and abnormal tissue and cells by having a slice, thin slice, and then you can stain it, and then you can examine it. But it does come with some limitations. And let me share with you what these limitations are. Some of the limitations, it's impossible with histology to see the entirety of cells and thick structures, because don't forget it's a thin slice of 2 millimeters or so, and it cannot be more than this. So if you have a structure, you cannot see it. Another thing, that's another dimension of the cell study, is the three-dimensional, which is the shape and volume. And in this case, with the 2D image, histology image on a slide, we all see from time to time, you cannot have this volume and shape information. Another thing, that by having physical section, that's irreversible process. That means it is impossible to recut the tissue in a different plane. So sometimes you need to have a transverse plane, so you cut the tissue like this, but if you need to have a coronal or any other dimension, you cannot do it again. That's it. Another damage coming from this physical cutting of tissue, it causes some tissue loss when you cut, even with a very sharp knife or very accurate procedure. There is some tissue loss, and there is also some distortion that will compromise the ability to have digitally 3D rendering, for example. So that's also another limitation. So what do we need here to avoid these limitations? What we need is 3D histology. And this is a new terminology, a new thing in medical imaging. Why we need 3D? 3D histology is needed to provide us with quantitative and volumetric measurement of scientifically and clinically significant data. So you need not only quantitative, but also the volumetric. And a 3D histology will enable us to produce safer drugs, to have more precise diagnosis, and to have more in-depth knowledge of the interaction of genes, chemicals, and disease in biology. And this is why we need 3D histology. How we can get this 3D histology? So in order to have 3D histology, you need both tissue contrast and high resolution. And these two things you can do only using a micro CT. We're all familiar with the CT imaging, but you need here a micro CT able to find 100 times very smaller structures than the conventional CT. And of course, in order to be more visible, you need contrast, and this contrast has to be metal-based strains. Otherwise, it will not work under the normal CT. So that's why you need the stain, special stains. We need a micro CT so that you could have 3D histology. And this will lead us to the main topic, that's X-ray histotomography and why it is useful. Actually, that was the work of Dr. Shing in the Penn State College of Medicine, who created this 3D histology model and technique, and they called it X-ray histotomography. So combination of histology, tomography, that's coming from the CT, and it's X-ray because it's imaging. And this X-ray histotomography enabled or make it possible to characterize tissue changes quantitatively. So it's not only per single cell or a small tissue, but for a whole big size of tissue, or even one small organ or one small animal, even like the zebra fish, for example. That's a small fish used in clinical research, and you can see the whole fish in one slide, and that was the images and the presentation front. And then also with this X-ray histotomography, you could be able to study the changes across hundreds of cell types in any millimeters to centimeter sized organism or tissue sample. So what is the ultimate goal of this? Ultimately, why we have this, we could have better understanding of how genes and environment contribute to phenotypes and result in healthier environment and safer drugs. And this is the ultimate goal of inventing this new technology. Thank you so much. If you have any questions, please make it at the end, and I will hand over to my colleague, Biz.
Okay, thank you. I want to, before starting my topics, I have a self-introduction in 3 slides because this is very useful for understanding my topics. In left panel, this is a robotic system for minimally invasive therapy for breast cancer using a high-intensity focal ultrasound beam. In upper middle image is a actual image. In this image, we can show the target and also therapeutic beam. And in this system, we can detect coagulation after treatment using the change of the stiffness change at focal point. In this case, imaging is very important for the check the assessment or control for high accuracy treatment. In this slide, we are developing a breast screening system in a startup company, Lily MedTech in Japan. This company is founded 7 years ago, and there are many problems in breast screening. This system solves all problems in breast screening. In left panel, people in prone position and lay down on the surface of the device, and each breast is inserted in the imaging area. In imaging area, a ring array transducer is positioned with a diameter of 20 centimeters and a 20,000 pairs element. In this device, in right image, typical clinical image, we can show easily the tumor in image. This system is a non-contact and a 3D image. That point is very important in my last half topics. And this device is no pain. That is very important, especially in Asian countries, because population age peak in patients is relatively young in Asian country, in 40 or 50s. In such case, pain is very reducing the screening ratio. And also, no radiation is the same point in this point. In this system, using ultrasound CT. And last my introduction, we are developing also AI for this new breast screening system. Conventional all AI performance is less than the teaching doctor to AI. But our unique system is beyond the doctor's performance because a combination of MRI. Both USCT and MRI is in prone position and non-contact and 3D image. Then we can check easily to the comparison and get a high accuracy annotation from both images. But USCT is very cheap compared to MRI. Then it can use in screening process. In left image, typical screening process, vertical axis shows the population. Current breast screening patients ratio is only 0.5%, and all people entry to mammogram, but mammogram can detect only half of the patients, in reducing the number of the actual patients in this process. And ultrasound and MRI, and to go to the final process to biopsy. MRI is a good detectability, but cost is too high. But our system combination using USCT and MRI through the AI combination, that is very good method we are thinking. From this slide, my topics. We are thinking non-contact and 3D and cheap imaging technology is very important to the close to the distance between the life science research and actual clinical image. Our USCT is one of the examples for breast screening. Because if we can get a non-contact image, we can check easily pixel by pixel in many images obtained in different day or different years. In that point is very important in screening because patient internal structure is highly dependent on each patient. But change is a very important information to get the leading information to the disease. And also, if we can follow many long time history in local information through the non-contact and 3D image, we can get more smaller tumor mass compared than current size limitation. And also, we can check some information before generation of disease in many screening data. And also, this follow-up in time history is very important in the checking the control of the preoperative chemotherapy, for example, in breast cancer, because size or shape change of the mass, and also change of the microenvironment, including blood flow information or scarring or many information can be visualized by adding the use of the contrast agent. In this case, non-contact and 3D image are very important. This is my last slide. Of course, AI is very important for these topics. Example, such a comparison to pixel by pixel, AI can enhance the performance of the calculation, computations. And also, I'm very familiar in this field, AI image diagnosis. That is very important, but also AI natural language process, example is ChatGPT, is also very important because the fusion of the many image and language interpretations. And also maybe generative AI is very important to this kind of fusion. But I'm not familiar in this natural language process and also generative AI. But I think this kind of combination is very important to improve the knowledge of this field. Thank you very much.
Thank you. So that's a good segue to what I'm going to talk about. I want to talk about artificial intelligence and machine learning and its application to medical imaging and life sciences. So the aim here is, when medical imaging came into being in, I think, due to X-rays by Röntgen, it changed how medical science is practiced. Like people could really see inside the body, and that had never been done before in the history of mankind. So that was a paradigm change. But all of it really depended on a human being looking at the image, a trained human being rather, looking at the image and deciding what is healthy and what is not. And now I think we are at the cusp of another paradigm change, wherein we have such large amounts of data that we could have machines look at these images and decide, hopefully with much better accuracy, whether there is a disease process, and if there is one, what is the prognosis, what is the treatment response, and all of that kind of stuff. So basically that's the aim, that we want to have an AI-assisted diagnosis and prognosis, and in doing so also have precision medicine, because each person's disease is unique, as you all might know, and hence we want to have treatments that are tailored to each individual. So I think my panelists touched on these aspects. So I'm going to basically expand on that theme, and then we can have a discussion on this. Okay, so what are the challenges here? The challenge is there's a lot of variability. So the variability is in disease presentation. As I said, that each person's disease is not the same, from all the way from oncology to mental health. And there's a variability in treatment response. For example, if you have 100 people with depression, a few of them would respond to medication, a few of them would respond to therapy, a few of them are treatment resistant, which means that they will not respond to any treatment at all. And we still don't understand why this is the case, okay? So there's variability in treatment response. There's another source of variability, which is quite underappreciated in modern medicine as it is practiced today, which is variability in demographics. The way a male responds than a female response is very different to treatment, okay? The disease process is different. People have also shown that the genetic susceptibility in certain racial and ethnic groups or certain diseases is more or less than others. So there's also this variability in demographics. When you have all of these sources of variability, it becomes all the more important that your AI or ML algorithms are really tailored to address this variability. And of course, we have large amounts of data. So the amount of data that is generated, as we'll see later, is large in terms of the size of data. I mean, each person's image takes huge amount of data to store, huge amount of resources to store, but we don't have large amount of data in terms of data diversity. For example, if you look at language models like ChatGPT, they are trained on a huge amount of data, but it's diverse data, okay? In medical imaging, that's not the case. We don't have diverse data because acquiring these images it's pretty expensive. So, I mean, we have a lot of data, for example, coming in from Europe and the US, which are basically from Caucasians. And we don't know how all the AI ML models which are trained on that data would apply to other racial and ethnic groups. And there's some research that's out there, recently some paper in Nature Neuroscience, which showed that they don't generalize very well. So that's another issue. And then we have regulatory and legal bottlenecks. So, because this is ethical. If you have some doctor decide on your health based on what a machine's telling him or her, then is it ethical? Who bears responsibility in a legal sense for the decisions made? So I really won't go there, but this is an important issue. Okay. I would very briefly go through the methods because I know we don't have a lot of time. So as you can see, there are gazillions of artificial learning methods, all the way from Bayesian approaches, which came from probability theory, and then you had decision trees, and support vector machines were very popular in the 90s because they're very simple, and then neural networks, the smaller ones in the 90s, and now we have deep models which kind of work very well. And then, you know, with various different ways of doing this. So if you want to do this, just picking the right kind of AI or machine learning model would be a challenge. They all work on different principles. I wouldn't go there. Essentially what they're doing is you have some kind of a feature space where you're trying to draw decision boundaries, and then once you have new data, which is basically the patient, the new patient that you want to diagnose, you will see whether they fall on one side of the decision boundary or the other side, and then decide which group they belong to, okay? Neural networks essentially do the same, but they do it based on, by basically tuning the weights of the perceptrons. Decision trees are kind of interesting because they mimic the human decision process. So for example, you know, you see the outlook. If it's sunny, then how much is the humidity? If it's high, then you know you do have a yes or no answer. So, and you know, this is one example where we use a decision tree to basically mimic the diagnostic process of autism spectrum disorders. And all of these different methods are different in the sense that the way the decision boundary is created is different. For some, they are linear. For some, they are not linear. For some, they can have arbitrary shapes. So sometimes, you know, having these arbitrary shapes actually improves the classification accuracy. So how do we, I'll give examples of implementation of these methods. I mean, there are, as you can see, a lot of different methods on a few data sets. I work in mental health and psychiatric applications, so I'll show a few of those. There are many open databases nowadays in mental health. ABIDE is Autism Brain Imaging Data Exchange for autism. Then you have ADHD, which is attention deficit hyperactivity disorder, PTSD, post-traumatic disorder, and ADNI is a very famous database, worldwide database of Alzheimer's disease. So you can, I mean, we have run these algorithms on all of these data sets, and you can see the accuracy is kind of okay. It's not as good as you want it to be for application in the clinic. I mean, sometimes they go all the way up to 90%. I will not bother you with these charts. But the point is, we want to combine different classifiers to get better and better accuracy. And the point I was making before is the accuracy varies a lot based on age and other demographic factors. So we can also go back and look at, for example, this is the brain, and if you look at autism spectrum disorder, you can, the advantage with machine learning algorithms and AI algorithms is you can go back and look at those. For example, if you look at autism, we found that these connections were weaker in people with autism. So this then becomes a biomarker, which potentially somebody could pursue, do clinical trials. I mean, we've really not gone that, no company has really gone that distance, but potentially it's possible to basically do a phase 1, 2, 3 clinical trial and then see if this is an actual biomarker that could be used. So I don't know if many of you know this, but most mental health disorders are diagnosed based on clinical observation, right? It's not as if you do a blood test and if this is this value, then you have autism or depression. So it's basically very, very subjective. And subjectivity is really not scientific. So we want to have objective biomarkers wherein the diagnosis is really not dependent on a person's, what a person thinks. So, and this is basically work towards that. And I'm showing this for different disorders. So generally, I want to have some time for like a discussion. What we find is that the generalizability of these machine learning algorithms on in the field of medical imaging is a challenge. As I said, the data size is large, but the diversity is small compared to the very successful language models. But the payoff for solving these problems is big. Why is it big? Because, as I said before, there is huge diversity. So suppose you have some kind of a psychiatric disorder, you go to the clinic, the doctor essentially is doing a guessing game. They'll first do therapy. If it works, fine. Otherwise, we'll try some medicine. If it works, fine. Otherwise, we'll do some surgery. If it doesn't work, then you're up to yourself. That's how it's being practiced today. So what we want to do is actually use medical imaging, and what I'm telling is specifically in the area of mental health, to basically have very objective way of diagnosing and also determining prognosis. So this is my parting shot. So do you remember the days before Siri? There were a lot of machine learning algorithms which really struggled to understand human speech, okay? And then Siri came along, and then it does a pretty good job right now. So I think, with time, the same is going to happen with medical imaging. So things are going to get better, larger processes, more data, better algorithms. So we're going to get to a place where these things that I'm talking about are possible. That's the end of the presentations we had. I would like to start the discussion with my panelists here by asking their opinion about, first, the future directions in medical imaging technology as such. I know you've talked about X-ray and ultrasound, and also like tissue imaging, and then how AI and machine learning can impact those directions.
In my opinion, AI is very important because AI has an application for analysis of language And also, generative AI is also very important. Then, if fusion of the image analysis and language interpretation, we can advance the classification or more detailed analysis is very easily to progress.
Okay.
For me, I think one of the big advances we are making in science is artificial intelligence, machine learning and artificial intelligence. And one of the early adapters for this is medical imaging and radiologists in particular. And I remember a couple of years ago, there was lots of discussions and upset by the radiologists when the artificial intelligence was into the picture, because they thought we're going to lose our job. And that was real. I mean, it was not a joke, it was real conflict, and some doctors were really upset. And the idea is that if you understand well, as you explained very well, the artificial intelligence and machine learning role, one of the big things this can add to the technology is just it can give radiologists time to focus on the disease by excluding the normal. So imagine just giving one example for breast mammogram. There are some statistics that for every 100 mammograms, only 3 patients out of each 100 mammograms have issues. And this needs to be analyzed, and then it could be a disease or maybe not a disease. So what happens with this 97 normal, completely normal mammograms? They take time, they take efforts. In some institutions even, there must be double check. So can you imagine? You waste 97% of your time looking at normal mammogram, and you cannot overlook it, because if you missed one patient, this patient will be your responsibility as interventional radiologist or as, imaging doctor. So what happened? The AI excludes the normal by triaging, by having only giving you 10%, 20%, 30% according to what you need to focus. So that's when doctors realize that it is added benefit. Of course, for the patient, it definitely makes a lot. Another thing, that's new techniques, new modalities, like the X-ray histotomography I just explained, developed in the Penn State University by Dr. Shing, who they combined the histology, the traditional histology. We all learned it in the medical schools many hundreds of years ago. Histology is used, but now you optimize this to a different new land. And this is where I think this new technologies is taking us and to new frontiers, new advances, and whether you like it or not, it is coming, so it's better to be equipped for it. And this is my opinion about the topic.
Yeah, it's interesting because I remember the day when I had a friend in Stanford who practices medicine, and I went and told him, you have all this data, why don't you share it with me, and we'll train a machine learning algorithm to do the diagnosis. And what he said was, come on, man, I don't want to lose my job, because you're trying to do things that, I told him that you're not going to lose your job. And this is the reason why, because of the legal requirement that somebody must take responsibility for the diagnosis. So once we've had ChatGPT in the last year, I mean, I am also an academic editor at Frontiers. It's a scientific journal. So we've had some authors put ChatGPT as one of the authors, because they used ChatGPT to write their papers, and they felt that ChatGPT should be an author. Now, Frontiers has a policy that ChatGPT cannot be an author, because being an author is not just contributing to it, but also taking responsibility for that material. And ChatGPT cannot take responsibility for that material. So however good AI or ML algorithms are in diagnosing diseases, they're never going to replace a physician, because they can't take responsibility. It's always the physician's responsibility. Yes, they can take its advice. That's why we always talk about AI-assisted diagnosis. They're just being used as a tool to assist the physician, for the physician to make a better decision. But ultimately, the decision belongs to the physician.
I cannot disagree more with this, but also you touched it based on ChatGPT. And we all heard the news. It was concerning for me and for many people. When ChatGPT was able to pass the US medical licensing exam and get a good score, high score, enough to be a doctor. And this is, you start thinking, oh my God, where are we heading to? And as you mentioned, there is a fine line between contributing and taking the responsibility for this from a medical legal. And this remains still in the hand of physicians, for humans, but it's alerting for the future.
Yeah, there's one more point I would like to make, and I would like your thoughts on this. I have a physician friend of mine, and who when we were having a discussion about this topic, who narrated something to me. So he said that a patient came to him. He's a general practitioner with persistent hand pain, okay? And they did a lot of tests, and everything was normal, and he didn't know what to do. He said that based on his intuition, he decided that the hand pain did not originate in the hand. It was referred, okay? And this is not there in any medical textbook. So and let me come to that later. So, and then he said that this could be because of some kind of a tumor mass in the body, and that pain is being referred to the hand. And then he asked the woman to get an MRI, and it happens that she had an early stage breast cancer, wherein she was diagnosed, and she got surgically removed, and she's alive and well today. So the point he wanted to make was, if you used an AI algorithm to do this, it wouldn't be able to do it, because its knowledge is based on the textbook. And the path taken by the physician in this particular case was not based on the knowledge in the text. It was based on his experience and intuition. So goes back to my point before that I was making, that human beings will always have a role in this. We don't need to get so afraid of our artificial intelligence. But I think we need to make good use of it. That's my point. Absolutely. Any thoughts on this from the audience? We have 8 minutes left. Yes, please.
Just a quick question. Can we repeat the presentation? Now the room is full. No, it's just a joke.
Thank you, panel. My name is David Golding. I'm very interested in the AI angle, and in particular, I think I'm interested in the policing of AI. Okay, so what I fear or feel that we have here is globally, we have pockets of people using AI to their own devices. And if it was gene therapy and people were able to use CRISPR and do what they wanted, I've got this feeling that there's a global police force maybe looking at that. I think the thing with AI is that it comes down to the data set and the inherent bias that might be within data sets. So I just want to get your opinion on what you feel exists with governance of AI, its use and development. Is there any? Should there be any? What's your feeling on that, please?
Can I? So as of now, we don't have a very strict legal and regulatory framework for this, because it hasn't really come to the clinic. It's kind of in the research domain. But I can tell you that at least in the US, if you have to get research funding from the National Institutes of Health, and for any experiment wherein you're using some kind of an AI algorithm, you have to show that your sample is diverse enough. Like, it has both men and women. It has all ethnic and racial makeup of the society, so that your results really apply to the society as a whole and not to one group. And unless you do that, they won't give you the money to do that research. You can argue in certain cases why you cannot do that, or why as a first step you would probably want to do it in a smaller group and later expand it. But research funding agencies are right now very well aware of this issue. And I'm assuming if that's, I mean, NIH basically receives money from the US Congress, so if this thinking is there in the government, when this comes to the market, I'm sure FDA and other regulatory agencies would probably impose the same conditions. Thank you.
Just a little comment to add to what was mentioned. Totally agree with it. That you're absolutely right. Thanks for raising the question, because one of the drawbacks of AI is the true representation of the data sets to the global community. We all, any clinician, anyone who's in the field knows that the patient in the US is not like in Egypt, like in Japan. There's different genetics, different environmental, hereditary, different reasons to make patients are different. And any clinician knows this. So the problem now is AI, no matter how big the data is, like in breast cancer, for example, we have 1 million. Companies are saying we have a 1 million mammogram data set. But if you look at the true representation of this, it is not applicable to the heterogeneity of the whole world. And there is something need to be done in this to have this true representation of these data sets, because again, that's one reason, one alert. We should be, those who are involved in AI and machine learning should be working hard to get over this, really to generalize. I'm not talking here about the health equity issue, because it's a more bigger issue, that not everyone receiving the same equal treatment or diagnosis, chance to be diagnosed, but here is specific about technical differences, and there is a lot of work to be done. As far as I know, there start to be more concerns about this, and they are trying to find a way, but not yet. We're not there yet. I mean, that's a big gap in the AI when applied to different countries. Thank you.
Thank you. From my point, I think there is huge limitation of current AI image analysis, because the performance should under the top leading doctor. That is a huge limitation. Then I think two possibilities are important. One is a connection through AI, independent, different knowledge. That is very important. And also generative AI is very important in my opinion, because we cannot see the inside of the brain of doctor. This image is disease or not. That information is very discredited. But many generative image, we can understand doctor decide this is a disease or not. Then I think generative AI is a kind of a mirror to see the inside of the good doctor's brain. Then I think a very promising method.
Yeah, certainly agree with that. Yes, please.
So thank you very much for your great presentation. I'm Tetsuya Yamada from Auburn Healthcare. Since we are selling the devices, home healthcare devices, and then I want to know, this is not imaging, but I want to know the future of the time series data and the prediction by using the time series data, like BP, daily BP, or daily ECG waveform, that kind of data, if you can available, can you create an algorithm to predict the diseases?
Yes, a lot of work has happened in that. Mostly, a lot of the methods for time series analysis has already been developed in economics, because all the stock market data is time series. And there's huge money to be made if you can predict the future or predict whatever in the stock market, right? So there we have excellent models of time series analysis, and now those models are being tested on, for example, EEG, ECG, and all of these time series. And I know there's a few companies, especially companies which make like smart watches, like Apple, they're really interested in this, because you can record all of these time series using the smartwatch. And if they can make such predictions, and you know, my smartwatch is going to tell me, oh, you're going to have a heart attack. So that's really useful, right? Especially for old people. So I know there's a lot of work on that happening both in the industry and academia. I think we are almost out of time, so thank you for the opportunity. I think we had a very good discussion.
Thank you very much, panelists. Imaging, medical imaging. Thank you.